Hello and welcome to Table Talk. I'm your host, Karen Wilson. My guest today is local physician Dr. Danny Glover, and we are going to talk about Medicare, which can be quite complicated. Welcome to the show, Dr. Glover.
Glad to be here.
Glad to have you back again. But we're going to start off with some details about kind of a COVID update for our local hospital. Let us know what's going on.
Well, of course, we went through the recent Delta surge. And unfortunately, there were a lot of deaths, and almost exclusively from people who weren't vaccinated. So my advice would be get vaccinated, okay? But right now we have kind of a local situation in actually the state of Tennessee in that we have or almost have run out of the antibody. To get people up to date on that, if you caught COVID, and especially if you had a lot of health issues, we would give you antibodies to fight the COVID, which are man-made. That's it's called the infusion or the shots. And if you were counting on that as bailing you out if you got COVID, well, you can't count on it right now. We don't have any, or very, very little. And that little bit's being held for the very sick, the ones that are very high risk. This is a distribution problem. Everybody talks about the government. In this case, they're right. The government took over the distribution before you could just order it. And it's causing problems that we've had a shortage. We do not have a national shortage of the amount of antibodies, just getting it to places. And now there's a 2-week lag. And the last 2 weeks, we've been, well, 2 weeks before Thanksgiving, I should say, we had a good time. We were over the worst of the Delta, but it's still here. It's still infecting people. So, long story short, we're like 2 weeks behind of looking good, and therefore the post-Thanksgiving surge we're seeing is, we don't have enough.
Yeah.
So I would urge everybody to be very careful and do what they can, whatever they can do not to get COVID right now.
Right, and with all the holiday activities coming up, might be a good time to put your mask back on if you've not been vaccinated, or even if you have. Be a good time just to do. And then, of course, we don't know a whole lot yet about the new variant that I saw a map the other day that showed quite a few states had already had some cases.
Well, Delta still dominates, but to be honest with you, the variant, there's some hopeful news. It's not as frightening as I initially thought it would be. And the hopeful news is that if you have the third, the COVID booster, vaccine booster, it seems to enhance things enough within your immune system to fight this one. Okay, those who've only had the 2 vaccines or no vaccines, not so good.
Okay, so
and that's what it's looking.
Factor in your decision making in getting that booster for the new one, the new variant of it.
It's all about the antibodies. The antibodies you get naturally if you get the infection and survive, which most people do. Those antibodies are very good ones, but they only last about 3 months and they start to go down. And then keeping in mind we've only been doing this for 2 years, so we're learning as we go, which causes some people to say harsh things, but it's just the fact that we are learning, because this is a new thing. But if you had your vaccine, got your 2, say most people have the 2 variant of the vaccine, then we found out that's good for 6 months, but then it starts to wane, hence the booster. Okay, now if you actually get COVID, whether you had the vaccine or not, then we would give you man-made vaccines. That's what we're talking about. We've run out of. We don't have that to give you. So my advice is don't get COVID right now.
Okay. Yeah, we don't want to count on something that, for a while the antibodies were readily available to us, but now we need to kind of rethink that until the distribution of it gets worked out a little bit better. Okay.
And to go along with that is, within my own practice of medicine, I lost 2 patients in the first surge of COVID when it first started. Have not lost any since the antibodies have come. And if they'll hold still, I'll give them the antibodies if possible.
Yeah, that's right. Well, thank you for the update on that. We're glad to share that with our audience because that's well-needed information as we go into the holiday season. I want to go back to the audience now and open up with our topic about Medicare because that is quite complex and lots of commercials and things going on about Medicare right now. Let's start with, at what point in our life do we need to start thinking about Medicare?
Well, I want to start off by saying I'm not an expert at this, and what I'm saying is what I've learned, but there may be those who know a lot more than I do about it, because I'm not an insurance expert by any means. We all know it's considered a retirement insurance, and the age that most people are going to be able to get Medicare is 65. There is exceptions, such as someone who on certain disabilities. If they're there for 2 years on disability, they may be qualified for Medicare. And there's some other odds and ends. But mostly we're addressing those who have reached 65 and older. And that would be, initially getting your Medicare, but at 65, but also the annual, it can change it, to a different plan that comes in between mid-October to mid-December.
And I guess as people are starting to consider retirement and their insurance is going to be changing a little bit, maybe it might be good to brush up on Medicare costs and things like that ahead of time as they're starting their retirement planning.
Well, if I had a recent experience. I turned 65 3 years ago, and that's where I really started coming to some understanding of this, more than being a physician. And what you need to do really is start thinking about at least a year ahead.
Okay.
And so when you hit 64, you better start thinking about it. And another caveat to it is, it starts when you hit 65, but it starts the first day of the month you hit 65, not the exact birthday. If you're born on the 15th, it still starts on the 1st of that month.
Okay.
So about 3 months ahead of time, you better have it pretty well arranged for yourself. What you want.
And going back, I guess, for those of us who are just beginning to make that transition and stuff, give us a rundown, I guess, of what original Medicare A and B is and how that works.
Be glad to. Well, this was a simpler thing at one time because that's all you had was original Medicare. And a number of years ago, a new product came out called Medicare Advantage, and we'll talk about that. But original Medicare works like this. There is a Part A, which basically covers the hospital costs, okay? And you do not pay for that. It's part of the deal. If you paid into Medicare over your working career, you're going to qualify. Okay, now if you didn't pay for it over your working career, you may have to pay some on Part A. Okay, but that's rare. That's not very many people in that situation. Just to kind of be a little more detailed about it, Part A, people call it the hospitalization insurance. It'll pay for inpatient care in the hospital. It'll pay for skilled nursing facility care. In nursing home care, if there's a reason to be there, but it will not pay for like long-term time in the nursing. It doesn't do that. Hospice care, it'll pay for, and home health care. Okay, that's what it's for, Part A. Now, Part B, you might call it the doctor's part. Okay. And Part B is it's just that, but you have to pay for Part B. Okay. You pay a monthly amount, and it's based on your income. So it could be as low as this is estimated. Say low hundreds up to $400 or $500 a month, depending on your income. Okay. And that would cover, just to be more certain about that. It is outpatient care, and that would be mainly seeing your doctor, getting tests that the doctor's orders, like go to the lab, go get an X-ray or imaging, things like that. It would be the Part B that would pay for that.
Kind of your normal testing, I guess, and things like that. Normal visits and blood work and things of that
That's
nature.
Where most people who don't get hospitalized are going to see Medicare. It's going to be the Part B part. Now, the Part B is interesting. You usually have a deductible at the beginning of the year, which varies each year, going up I don't know, it's probably around a couple $100 now. And you'll have to pay that before the insurance kicks in. A lot of folks don't understand that and get aggravated with the physician's office, not realizing they have to pay that unless they have a plan, a separate insurance plan that pays it, okay? And there's no way the doctor's office can avoid that. You've got to pay that. I have to pay it when I see my doctor. Yeah. And then your insurance kicks in. So that needs to be known, and because a lot of folks get frustrated over that.
Yeah.
And then it'll pay for prevention care, like tobacco cessation, annual wellness visits, nutritional treatments, flu shots, and other vaccines. Not all vaccines, though, but it'll pay for the flu shot. It'll pay for the pneumococcal or pneumonia vaccines, but not the tetanus shot and not the shingle shot. Won't pay for those.
Okay.
Okay. So that's interesting.
If that's a part that I guess is that the person has to pay for, then are there options as far as who they choose for their Part B provider?
No.
Okay.
That's still part of Medicare.
Okay, that's part of Medicare then.
It's part of Medicare until we get to the Medicare Advantage plans, and we'll talk about that in a minute.
Yeah.
Now, the thing is Medicare has this little trick, if you want to call it that. It says it makes its own rules about how much it will pay. The maximal allowable amount is what it's called. All right. And then when it decides what that amount is for that particular service, then it'll say it'll pay 80% of it. And so the patient is left with 20%. Okay? So you get into why you need a secondary insurance or a Medigap insurance.
Okay, now, that was my next question, this Medigap
That's
thing.
where you get into that.
Okay, let's talk about that.
Well, for that 20% it doesn't pay, then the Medigap insurance is, and by the way, secondary and Medigap are interchangeable. It means the same thing.
Okay.
Okay? Tell me how I'll figure that out.
Okay.
It's the same thing. And so what it amounts to is you get with a private insurance company and you get a policy that will pay. And there's lots of them. That goes from like, alphabetically, all through the alphabet of different forms. Now some Medicare has canceled and you can't get any more, and some not. It's a changing thing. But they'll be called like G and H and different alphabet letters, and that is gets confusing. But you need somebody probably to help explain that to you.
I've seen lots of commercials on TV right now because of it's coming kind of to the time where people are enrolling and things like that. And you want to make your loved ones aware, I guess, of what the goal of the commercial is, to sell probably something. But I'm assuming that those are Medigap providers trying to...
Actually, probably I think the bigger advertisement is for the Advantage plans.
Oh, yes, yes, the Advantage.
But there's probably Medigap providers too. The Advantage plans are really being pushed now, okay? And so you're going to get a lot of information. Every year during the enrollment period, that time when you can change the insurance, mid-October to about mid-December, you are going to get a lot of communications, phone calls, letters, whatever, from these companies.
Right.
Okay. And that also confuses people.
Well, and that's a time where you probably need to study up and do a lot of research on that, and they're going to be wearing it out, so because it's all about making some money.
It is.
So caution, I guess, as far as enrolling in anything like that. Do the research on it. Exactly.
And it's a lot of information to figure out. Yeah.
I noticed when I was on the government website about it that there are, they referred to it as extra help that you could get, I guess, for certain incomes for the drug cost. I guess that's income-based as well?
I don't think so.
Okay.
Now, getting back, we're talking original Medicare here, Part A, Part B. For the 20% that isn't paid, then you get your Medigap or secondary insurance, okay, which is would be a monthly cost. None of that covers drugs for the most part. Okay. Part B may cover, and this is confusing to some people, it covers like diabetic supplies. Okay, not diabetic medicines, but diabetic supplies. Okay, so I'll write the diabetic supplies like it's a prescription, but actually it's not going to go to the same payment scheme. Okay, so there you are, you got all of that, but there you don't have anything insured to pay for your medications.
Which is the expensive part.
Can be, if you're, for many people, it very much is. So what do you do? Well, then there's a Part D.
Okay.
Okay. So here you go again. With original Medicare, you got A and B, which comes through Medicare. Then you got your 20% Medigap secondary insurance, which covers that 20%, and it's from a private company, private insurance company. And then you got Part D, and that'll be for your medications, also from a private insurance company.
Okay.
Okay.
I'm with you now.
Are you
so
with me
that
now?
part's private as well.
Yeah. And you end up with Part D. What I did is, if you go to Medicaregov, I think.
I believe it was, yes.
And you can get into that. You can make an account. And I think when I went, you didn't have to, but now you do, I think. And then you can go to actually a calculator for Part D, and you put in your zip code, and then it'll give you what plans, Part D plans are available to you.
Okay.
Now that, again, that's not government run. They're just providing the information there for you to read through.
So it's kind of telling you, I guess, that I have heard a lot of in the advertisements, they talk about your zip code and things like that. It's kind of telling you what providers are available in your area.
Yeah. Like one that's available, out west may not be available here.
Right.
So to cut down on the confusion, that will tell you what is available in your zip code. So that's handy. Now but that still is tricky because, what if you say have rheumatoid arthritis and you're on what we call DMARDs, or newer medicines that help, stop that from destroying your joints, okay? Well, those are extremely expensive medicines, okay? And, one Part D plan may cover it well and another may not. Okay, so you've got to study up on that, looking at your medicines and then figuring out. Now, myself, I wasn't on a lot of medicines, fortunately, so I just got the cheapest one.
Right.
I could. I think it was called Silver Scripts or something like that.
Okay.
And I'm not promoting that.
Right.
But that worked best for me because I didn't have a lot of expensive medicines to have to wrangle. And there's other issues. Sometimes there's something called the donut hole.
Yeah, let's talk about that.
It was still kind of nebulous to me, but the donut hole, people are on very expensive medicines. The insurance will help them up to a certain part, and then it will stop if you reach that amount. And then you'll have a period there where you have to pay for yourself, and then it'll start working again and pay again. And they call that the donut hole, which is entirely stupid as far as I'm concerned, but there it is. I have no idea why that was put into
So maybe you've met your deductible in, even though you've met your deductible, maybe in like, say, July or something, you may have a period of time where it goes up, and now we're talking about prescriptions, is that correct?
Now, remember, deductible is more about A and B. Okay, not so much.
See, this is why we need you here.
It is complicated. And the Medicare deductible is at the beginning of the year, okay? And you'll have to pay the first couple of dollars, then it kicks in. Why they did it that way, I have no idea.
Right.
Okay.
So I guess with that part of it, the D, then you're talking about the donut hole.
Yes, if you have a lot of expensive medicines, you're probably going to hit that donut hole and have to pay for the medicines for a period of time.
Okay.
And that's a real problem for physicians and their patients, in that lots of patients can't afford to, so they just go off the medicine. They may take the medicine 3/4 of the year and leave it off the 4th, which is not a good thing.
No, right.
And so it's a real issue and problem. Now, there are deductibles in other things, and we'll get to that later.
Okay. All right. Well, let's talk about what have we not covered here. I'm sure there's lots more that we need to talk about.
Well, I think in terms of original Medicare, I think we've covered it. Okay, and original Medicare is sometimes called traditional Medicare also, but it means the same thing. It means the same thing, because that's important, because the language is confusing sometimes. So original Medicare and traditional Medicare mean the same thing.
Right.
Okay, just like I mentioned earlier, Medigap and secondary mean the same thing.
Okay.
So people hopefully don't trip on those. Okay. Other things that Part B will pay for this is interesting: clinical research, ambulance services, durable medical equipment, and like the diabetic supplies are considered durable medical equipment, and that, like wheelchair, cane, those sort of things, hospital bed, durable medical equipment. Okay. Which, if you notice around some of the communities, there's businesses that do just durable medical equipment, and some of the pharmacy we have in town will do that too. So that's varies. If you need an orthotic, like a special shoe, or a brace or something, that comes into Part B, not Part D.
Right.
Okay, so I might write it as a prescription so they can get the process started. They're usually more paperwork will come after that to me for that particular issue, but it's not a Part D, it's a Part B.
Right.
So Part D is basically just the medicines.
Right, okay, I'm with you there. Equipment, Part B, medication, Part D.
Correct.
Okay.
Okay, so hopefully that is helpful, because it's kind of confusing. Then we would go to the Medicare Advantage plan. So and that was something that was sprung on us, I guess, about 5 years ago or something. You never heard of it? No, so it was there. Medicare made a huge change in its laws, and it greatly affects the way I practice medicine. About 5 years ago or more, and then they really came into play where you had to do these things in 2017. Okay. At the end of 2017, and Medicare Advantage plans are totally private plans, and everybody's jumping into it. That's why you get all the letters. The big players here is Blue Cross Blue Shield of Tennessee and Humana. That's the two that's been here. But now Ascension Hospital System is getting one. Right now I think it's just centered in Nashville, and that's caused some confusion because our advertisement, we watch national news and stations, so we'll see that, and people are asking, well, why can't I get Ascension? Well, right now they're only allowed to be sold within Davidson County. Okay. Okay. So and then Cigna's getting on board. There'll be a lot of them before it's done. The downside to the Advantage plans are basically, you may want to go see a doctor and he's not on that plan. It's sort of like HMOs. The Advantage plan will contract with doctors, certain hospitals, and things of that nature, so you may not be able to go where you want to go. Okay, and so you really like this doctor for that problem. Well, you may have to pay extra to see that. They may pay some, but it won't be nearly all of it.
Kind of goes back to the in-network, out-of-network
Exactly, that kind of idea. Yeah, that kind of idea. And, an example of that has impacted us here would be Blue Cross Blue Shield Medicare Advantage, Blue Cross Blue Shield of Tennessee Medicare Advantage could not get to a contract with Vanderbilt. Okay. So people, who wanted to go to the Vanderbilt medical system may have had to pay out of network, if you want to call it that, a lot more money to see the people there. But fortunately, the vast majority of doctors and hospitals do take that, and it's a good plan, I think. But you do have like when somebody comes to see me, most of them have to pay a $10 copay. So copay is, it's not a deductible, because the deductible generally ends. The copay would be each time. Now, if you go up the ladder and see specialists, they may go up like to $45 and things like that. So that's something you probably wouldn't have been paying with the original. Okay. And if you need a test, say an MRI or this or that, you may have to pay a lot more on that test than you would with the original. With the Medicare Advantage, you may pay more. Okay. What it boils down to is the Advantage plan is really good if you're very healthy and don't actually use Medicare very much.
Is that the one we talked about that has a lot of, I guess, well visits? They expect you to kind of meet some thresholds as far as keeping your health.
Medicare, and that changes, I talked about it went on the past 5 to 10 years, and particularly kicked in 2017. Every part of Medicare is pushing wellness visits hard. Okay, so when your doctor's bugging you about a wellness visit, there is some reasons for that, because it may affect what the doctor is paid by Medicare. Okay, and the Advantage plans are doing that on steroids. Okay, they really are aggressive about it. And so if you're going to get an Advantage plan, you need to be prepared to follow what they want you to do. Okay. And that will be a lot of prevention, which is fine. Yeah. That's good stuff. That's my bread and butter as a primary care doctor. I like prevention.
Well, and it's so much easier to hit something off along the way.
Take care of it after it happens.
Instead of ending up in the hospital, long term, trying to fix something that's already gone wrong.
Now, in my practice, the traditional Medicare still dominates.
Okay.
But there's a steady growth of people doing the Medicare Advantage. There's some things I want to say about that. One, if you can't afford a secondary insurance in Part D, and you decide just to go with Medicare, okay, well, you're going to be liable for that 20% in paying for your medicines. And, you know, go see your family doc or your primary caregiver. That's not much money, really. Mm-hmm. But if you go in the hospital, run up $100,000 bills, you're going to owe $20,000.
20% is a huge part.
And so you really don't need to be out there with original Medicare unless you have the secondary in Part D.
Mm-hmm. Okay.
And so I really encourage patients who are in the situation where they cannot afford to pay for the secondary in Part D. I really push them to go into the Medicare Advantage plan, okay? Now, other things, I guess that's a good.
Good. I'm digesting all of it right now.
It's a lot to digest.
And I think I need to study up before the age of 65. And of course, things will change, I guess, from year to year. And so it's always good to brush up well in advance of turning 65. Thank you so much. You know, I'd like to give some resources as far as help making these decisions. Rely on your family members and friends. Some of the senior centers in your area may help with some of this. Every physician's different. They may provide some guidance as far as this kind of stuff goes as well, but really do your homework before making these decisions. So thank you so much, Dr. Glover, for coming and explaining this complicated process. I hope it's helped the audience. I'm sure it has.
I hope so, but to some extent I'm still confused about it.
Well, you're a participant, and you know, you have to utilize the insurance system yourself. Well, I'll say thank you for joining us today, and we hope our discussion has been informative. Join us again next week for more Table Talk.